start recording. Now, it has started. Let's present desktop is probably the easiest. So, I want to just go through some of the, I guess, somewhat complex stuff the way it's taught to you, but shouldn't be too crazy, because I'm not going to go through the crazy stuff of just about flow and pressure and oxygen delivery in reference to your heart. So assuming you've got enough oxygen from breathing, what happens after that? So really just, I mean, you guys have studied exercise phys, so in certain ways you'll know this better than I'm trying to describe it to you. I'm just trying to give you the simple version so that you can work out pathologies without having to understand every single detail about different pathologies. So this you have probably had to memorize in some way, shape, or form in your exercise phys degrees, yeah? Is this complex as hell? Yeah. Does this like make a nice, simple way for you to approach things? No. But really, this is what we talked about at the alveoli. So how much oxygen you're getting in and how much CO2 you're getting out in the fact that it's exposed to external air. So they're the pressures of the external air, expired air as opposed to external air. Inspired air is that one, 160, yeah, fair enough, and CO2 close to 0. And so they come out to average around particular numbers, and then the red cell goes to the pulmonary veins, back to the, what part of the heart? Left atria to the, before that, what's the big artery called? Aorta. And then from the aorta it goes out to the body. So the capillaries. And then at the capillaries you have gas exchange as well. Yeah, plenty of surface area and very thin walls. So oxygen leaves and CO2 comes in. So the saturation of each hemoglobin goes from 100 down to 75. And what fills that extra space? Carbon dioxide. Haldane effect, if anyone wants to play along at home and you want to Google it. So it comes back via the veins and the vena cava, and then from the veins and the vena cava it goes to the right atria, to the, yeah, to the, nope, what leaves the heart? Arteries leave the heart, veins come back, yeah? Somewhere in frickin' high school they taught you about oxygenated and deoxygenated and confused the shit out of you. That to everyone. Everyone says the same things. They don't get the concept of leaving. So, much simpler than what you did before, and it's exactly the words I just used, is this. What do we have? The pump in the middle, yeah? So if we track blood from the lungs, the capillaries, it goes to the pulmonary vein. So we're just a red cell traveling along, yeah? And then from the pulmonary vein to the left atria, to the left ventricle, to the aorta, to the organs where the capillaries are, to the vena cava, right atria, right ventricle, pulmonary artery. Same loop. Now, we have arrows because that is the direction of flow. What makes that the direction of flow? What else do you need other than a pump? Valves. And where are the valves? Where are the main valves in the heart? You have an aortic valve, yeah? And you have, so that's going to the aorta, and the one going to the pulmonary artery would be called the pulmonary valve. So what are the ones between the atria and the ventricles? So between the right atria and the right ventricle, you have the tricuspid on the right. And what's the one on the left? What's the one that ends in L? Mitral. Mitral on the left, yeah? Tricuspid on the right. Don't say bicuspid because there is a pathology called a bicuspid aortic valve that you would get aortic valve surgery for, yeah? That's all. So that's the only time you'll see bicuspid used. A genetic, congenital kind of abnormality where you have only 2 leaflets instead of 3 for your aortic valve, and the long-term problem from that is turbulence, calcification, and you end up getting a valve replacement at some point. Make sense? It is the mitral only has 2 folds, but don't call it the bicuspid, call it the mitral. Because the only time you see the word bicuspid in a sentence in A hospital is a pathological a valve getting replaced. So yes, it only has 2 leaflets, but call it mitral. Is that beeping? What's dripping? Yeah. So blood travels around in a circle. You got 2 things to remember: flow and pressure. Cardiac output equation, which is your times heart rate. Yeah. So if you want more flow, you just increase your heart rate. And if you want more pressure, what do? Increase your heart rate, because that increases your cardiac output, which increases your blood pressure. So let's put those things back into a pretty picture. In the way we kind of look at these things. So people get confused when they're looking at chest x-rays because they forget that all the white stuff in the middle is blood and blood vessels, yeah, which is mostly water. So you can see there a more pictographic demonstration. So this is the aorta running down. This would be the patient's left, which is my right, but looking at the patient, it would be their left. Running down that left-hand side of their vertebra is the aorta. And then that goes up and down, and then coming back on the right, because it goes to the right side of the heart, is the vena cava inferior and vena cava superior. Yeah, back to the right atrium, right ventricle. Now your heart is in a position where it's not central and it doesn't look like a cartoon heart. It looks like that one over there, and it's rotated in such a way that most of your right ventricle is anterior to your left ventricle, kind of thing. Yeah. So we just said the perfusion or Q or cardiac output equation is heart rate times stroke volume, and the gas movement equation is ventilation, or minute ventilation, which is respiratory rate times tidal volume. And having more of those, more of one and less of another, is a VQ mismatch. Yeah. Not really important as long as your numbers are okay and the problem is sustainable. The issue is not, is it abnormal? Is it going to kill me today or kill me in 20 years from now? And if it's going to kill you in 20 years from now, you'll just cope and then die in 20 years, which is not a bad thing if you're 60, but I guess if you're 5, then it might be. Yeah, and you do get congenital abnormalities that shorten your life expectancy in all sorts of ways. Cystic fibrosis, lung, sad face. Yeah. Does your heart have to work harder because your lungs are sad? And does your heart end up failing because of that? Yeah. And that's cor pulmonale, cor coronary, Latin word for heart, pulmonale, Latin word for lungs. Heart sad face because of lung sad face, and the side of your heart that pumps to your lungs is the left or right? Yeah. To the lungs, right. So if you have really sad lungs that are stiff or whatever, does your right ventricle have to work harder? Yeah. Does it remodel in the short term? And does it fail in the long term? Yeah. That's it. Back to what this picture's telling you. Yeah. If I just stick sad face here at the lungs, yeah, like if I stuck my thumb where that cursor is, there would be a problem of blood going past my thumb. So there is back pressure backwards. Yeah. We'll talk about that tomorrow when we're doing a bit more pathology. But that's the idea of that graph. Wherever you see the word as the pathology, stick your thumb there. Locally, there's a problem. Back pressure, and then going forwards, there is less flow and less pressure. Yeah. So think about a blockage or something like that. So panic is just increasing respiratory rate and increasing your heart rate to increase oxygen getting and oxygen delivery. Now, what are we doing with all that oxygen? To do what? Making ATP. So what is ATP? It is our store of energy that then separates into ADP plus phosphate to release the energy. Where does that energy come from? Glucose. Where does the glucose come from? Sugar is glucose. And where does the sugar and glucose come from? What makes glucose? From fruit. What makes fruit? Yes. Plants. So where do the plants get the energy from? The sun. This is it. Understand photosynthesis and you'll understand how to make wood. And then burn wood and you'll understand how to release energy. Yeah? So think about a plant. What does a plant need to not die? Water and sunlight and air. So what is it getting from the air? Carbon dioxide. So that's where we get our carbons. Now, is the carbon dioxide, or is it something that you add water to? Yeah, so CO2 plus H2O gives you carbon that is wet. And when you are well, I guess, drinking water, you are well hydrated. So we call it carbohydrate. Carbon that's hydrated. No one realized, I only realized that sometime recently. Let's not pretend I've been explaining this to people that simply before. It just clicked for me maybe late last year when I was doing one of these talks. I'm like, hydrated, water, carbon that's hydrated. Yes, it's not simple. Yeah. So when the carbon is hydrated, yeah, you've got CO2 and you're taking the carbon, and then what are you giving up? No, oxygen. Yeah. So what does the plant leaf release? Oxygen. And then the oxygen goes into the atmosphere. And then what do? Breathe in the atmosphere. And what do we breathe out? Plant food, to misquote that beetroot of Barnaby Joyce. He's an idiot. So the idea is that a plant takes energy from the sun, photons and all that kind of stuff, uses that energy to stick carbon to water, carbohydrate, and it uses the carbohydrate for energy, but it also uses the carbohydrate to make things. And what is one of those things it makes? Wood, cellulose, lignin, all those kind of things. Are just arrangements of glucose. Yeah. What else does it make? Fruit. Yeah. And do we eat fruit? Yeah. Do we eat leaves? Yeah, you weirdos that eat salad. Do we absorb much out of the leaves? No. There's a bit of stuff, but the actual leaf material just goes straight through you. Yeah. Why? Because, yeah, it helps you poop. Because you don't break down cellulose. Cellulose is full of glucose, but it's not a form that we can break down. Yeah. So when they say, oh, you need to have more fiber, you need to have more fermentable fiber. Otherwise, it's just wood. So can you burn wood? Yeah. And what happens when you burn wood? Release heat and light. So that's the photons that we captured from the sun. Yeah. And what else? Carbon dioxide and water, because you're breaking carbohydrate back down. Now, what do you need to put into that in order for a fire to burn? Oxygen, yeah? You need oxygen, because if you put a box over the fire and no more oxygen can get in, all the local oxygen is used up, and what happens to the fire? Yeah, it goes out. Gets a bit sad, gets all smoky, and other weird things happen, yeah? Weird combustion, yeah? You know what smoke is? Incomplete combustion, yeah? Like when you put out a candle and all that kind of stuff. Yeah, that's all. You see all those things? So I want you to think about failures of this as that. Like, what are we getting? Well, not carbon dioxide and water. So some other things. An incomplete combustion. Yeah. So the carbon comes from the carbon dioxide in the atmosphere to make carbohydrate. Hydrate just means water. They separate back out to release the energy. And that is called cellular respiration in primary school. Oxygen and glucose come in, carbon dioxide and water come out. In high school, you learn that that's called aerobic metabolism, because aerobic means with oxygen. So therefore, we learn the one without oxygen, which is anaerobic metabolism. Different endpoints, yeah? Smoke and soot instead of a clean burn. So what is the endpoint that's not a clean burn in anaerobic metabolism? Lactic acid. And what will that do to your pH? Decrease. Now, forget that. What is aerobic metabolism producing? Like in terms of it's a clean burn, but you're still getting something that's left over, which is carbon dioxide. And can carbon dioxide dissolve into water? And does that form an acid? Carbonic acid. Yeah? So they're both acid forming. But the problem is not that they form an acid or don't form an acid. Carbonic acid is an acid. Lactic acid is an acid. The difference is if you have aerobic metabolism, for every glucose, you make how many ATPs? 30 something, yeah? I don't remember the math. But if you have the incomplete burn without oxygen, how many do you make? 5 or 6 maybe, yeah? So it's much less efficient. Now this is going on all day, every day, in that you don't have a zero lactate or lactic acid right now, yeah? And if, as you've done the lactic threshold training, having lactic acid doesn't kill you, but does it feel pleasant? Yeah, it feels like dying feels like burning, feels like you're on fire because it's not the normal reaction. And does that sound like something that'll make you panic? And if you panic, should that increase the amount of oxygen coming into your mouth? And if you panic, does your heart rate increase? So should that increase the Q that's meeting the oxygen? And should that deliver more oxygen to your tissues? Because you've got a higher heart rate and a higher breathing rate. Yeah. And should that clear more CO2 from your body? And what should that do to your pH? It should help bring it back to normal. Now, you still generate a lot of lactic acid, which is not pleasant, but you can maintain that for a non-zero amount of time. How long did you have to maintain that for, or try to maintain that for? 30 minutes? Jeebus. Yeah, anyway. So there you go. And you're training at a lactate of about 4, aren't you? For some time. Now, is that sustainable for more than that period of time? No, because... Oh, we'll get to that. So what is... It's very... So I'm not saying this is the perfect science, but it's a very simple way to think about it is, what is your stomach full of? What kind of acid? Hydrochloric acid. So if you are vomiting, what are you doing to the volume of chloride in your body? Yes, if you have less chloride in your body relative to the amount of sodium, sodium is an alkali. Chloride is an acid. You are doing a stomach compensation for a metabolic, electrolyte, whatever version of that you want to call an acidosis. Yeah, so you're trying to decrease the amount of acid in your body by just launching acid out your mouth. Xenomorph style. Yeah. Now, don't quote me on that as the absolute science. That's just the way I remember it in my head, because that helps you solve ABGs. What is this person doing? Vomiting. Okay, what's happened to the volume of acid in their body? Aha. What's this person got? Diarrhea. So you lose acid out that end. What do you lose out the other end? Alkali. Yeah? Yeah. Think about what happens in your gastrointestinal tract. Stomach is full of acid, and then that gets neutralized with your bile salts. Yeah, alkali type stuff. So you need acid to do what to protein? Denature protein. And if you denature protein, it opens up. And then what do you use to chop it up into amino acids? We talked about this. A's. What kind of A's chops up protein? Protease. Yeah? So that is to absorb the protein, you need to chop it up. Yeah? You can't absorb a hunk of collagen. Yeah? You need to cook it, acid it, do whatever. And then you can absorb the collagen type thing. Turn it into gelatin, basically. So then what are your other macros? Well, glucose you just absorb directly. But if they're branched chain glucosey things, you need amylase. Yeah? And then what's the other main part of food? Fats. Now, do fats dissolve in water? So how do you make fat dissolve in water? You turn fat into soap. You guys all watch Fight Club? Yeah, what is he making in Fight Club? Soap from fat that they're getting from the liposuction clinics. So what do you add to fat to make it dissolvable in water? Sodium hydroxide. The sodium attaches and then generates a thing that's polar and then can be absorbed across your lipid membrane. So what are we doing? Not sodium hydroxide, but sodium something something. Bile salts are alkali. The alkali turns fat that's not soluble in water to something that's a polar molecule that you can then absorb. Yeah? Make sense? But yeah, effectively, Fight Club. Watch Fight Club, it will make more sense. Yeah. And one of the remnants of that is glycerin. And if you add nitric acid to glycerin, you get GTN, which is glycerine trinitrate. Yeah? And what is GTN used for in the hospital or in medicine? It's a smooth muscle relaxer. So what's that going to do to your blood pressure? Decrease it, because it will vasodilate. Yeah? So it'll decrease your pressure. People that are having chest pain, all that kind of stuff, GTN. People that have a high blood pressure might have a patch. Yeah? Now, if you rearrange glycerine trinitrate to nitroglycerin, what does that do? It goes bang. Yeah, that's all. Watch Fight Club. All this, like all of the physiology will make sense if you just understand what they're doing in Fight Club. Yeah, there's a good old scene where he kisses the back of the guy's hand and so on. You go, that's acid base at its finest. That's all. So, how did we get there? Who knows, but that's how I learn things. Yeah. Yeah. So, I mean, but diarrhea is just losing salts. So what's that going to do to the electrolytes in your blood? Yeah. Now, if you don't put adequate electrolytes back in again, what are you going to do? Yeah, dehydrate and lose enough electrolytes that you don't function well. So thinking about potassium sad face, is that going to be bad for your heart doing its job? Yeah. And sodium sad face, bad for your nerves doing their job. Yeah. Is that going to make you like more or less able to get to the fridge? Yeah. And then you're going to like have the Gatorade that you put in the fridge earlier, and so on. Yeah. So ATP is the energy for everything that you are is moving electrolytes back to why electrolytes are important. Because if you don't have enough sodium, do your nerves do the nervy thing? No, you need more sodium outside than inside. But when the sodium comes in, the sodium channel's open and sodium comes in, how do you get the sodium back out of the cell? Pump. And what do you need for the pump? Energy. And what is that energy? ATP. So think about a muscle. I mean, everything is sodium, but what is the other thing, other electrolyte you think about when you think muscle? And? What's the excitation coupling? Calcium. All of the above, but if the electrolytes come into the cell and do their job, yeah, what do you need to get the calcium to undo from the actin-myosin thing, from the tropomyosin? What do you need to get it to unbind? ATP. But the calcium is still in the cell, so what's it going to do? Trigger it again. Does that sound like a cramp? Yeah. So if you don't have ATP to unbind, you stay locked. And if you don't have the ability to move the ATP back out of the cell, yeah, what do you need to move something against a pressure gradient? A pump. What do you need to run the pump? ATP. Yeah? So if you don't have ATP, the calcium doesn't unbind and the calcium doesn't leave the cell and it stays locked. And that is rigor mortis. Yeah? Or in your experience, a cramp. It's not the same thing, but think about it the same way. Is a cramp a muscle contraction? And does it relax? No. Did you ask for that? Something locally happened, i.e. you got a bit too lactic. And when you get lactic, what happens to the shape of proteins? Denatures. Now, what are those gates made of? No, the gates are made of protein. What is actin and myosin made of? Protein. What are the pumps made of? Protein. Change the shape of protein. Does it do its job? And that's where pH becomes the problem. Does that make sense? No matter what the cause of the pH is, the protein changing shape, enzymes don't work, gates don't work, pumps don't work. Yeah? And at what point does that create sad face in your heart? A pH of less than? You can have people down to 7.2 and they're perfectly happy, as you would have been when your lactate was lactating. 6.7. Blood. Now, your muscles are already below that. Your muscles are probably running at 6, pH of 6 on a good day. But if there's 6 there and then there's 7 in your blood, then the hydrogen will move away. Yeah? But if the gap isn't that big, the hydrogen stays locally. Hydrogen is the H in pH. Protein, sad face. Does that make sense? Yeah. Now, it's supposed to be happy face, not sad face. So oxidative phosphorylation is moving ATP. P is phosphate. Phosphate is a rock. So if the rock is moving, it's alive. And if the rock is standing still, it's a rock. Yeah? To dust you shall return. That's it. You're a bag of water moving electrolytes around. So, exactly. That's why we need coffee. So to just take a snippet of that, to throw the equations in there, when you're learning cerebral perfusion pressure, as in CPP, is your mean arterial pressure minus your intracranial pressure minus the jugular vetus pressure, yeah? So blood has to come up your carotid, through your skull, inside your skull, and then back down the jugular vein, yeah? So if I just block your carotids, what's going to happen to the pressure and flow of blood going into your brain? Decrease. What's going to happen to oxygen delivery? What's going to happen to glucose delivery? Yeah, and so the mitochondria in your brain that are very energy hungry, are they going to just get angry and hangry? When they get hangry, what do they eat? Your brain and themselves, both. But yeah, because what's your brain made of? Fat and protein. Does that sound delicious? Yeah, damn straight. That's all. You've eaten brains. I've eaten lamb's brains a lot back in India. So the intra-organ pressure is the intracranial pressure. And what have we seen that increases the intracranial pressure? In what way? Yeah, or yeah. So what's that called? Hydrocephalus, because there's too much CSF in there. And what's the other one we've seen? Yeah, hemorrhagic stroke, increasing the intracranial pressure. And what will that do to the perfusion pressure? Decrease it. Now, if it's an arterial bleed, is that going to be a lot of pressure and volume in your head? Yeah. So it's a much quicker increase in intracranial pressure. But can you have a venous bleed? Yeah, your subdural hemorrhages. Slower, less pressure, but still bad for your brain. Now, can I just stick my thumbs on your jugulars? Yeah. And what's your head going to look like? Very red. Why? Because blood's coming up, but not leaving. So what does your head do? Increase in volume and increase in pressure. Yeah. That's how the venous sinus thrombosis that people were dying from, because people die from it all the time. But yeah, it's like, oh, they're having these bad brain things because of the COVID vaccine. It's like, yes, they are. But we've had 3, and we should have 20 every year. So if statistically speaking, there should be 20 of them every year, and we've seen 3 or 4 of them. The COVID vaccine making them more or less likely? Less likely, statistically speaking. There is a paper from, I was like, I got to look this up. Paper from the Netherlands from 2010. Yeah. What is the incidence per 100,000? What is the current incidence per 100,000? More or less. If the answer is less, protective. Yeah. That's how stats should work. Not, oh, this one person had some problem and everything's bad. So this is the way the equation lives. And the equation lives back in this lovely diagram back here. So you can replace any organ you like in there. So it could be your kidneys. And what compartment are your kidneys in? What's this called? Abdomen. So if you had an increased intra-abdominal pressure, yeah, is that going to squash your kidneys? Yeah. Is that going to decrease perfusion to your kidneys? Yeah. Or if you just have really low blood pressure, is that going to be kidney sad face? That's a lot of our patients. You see how many patients in ICU end up on dialysis. Why? Because they were sick for whatever reasons, heart or blood pressure or sepsis, and their kidneys don't get enough blood pressure and then they crap themselves. You have some issues with, I guess, pressure, but you also stretch out in a way that the volume is expanding. Obviously the pressure is increasing, but the volume is expanding. It's not a fixed space, as opposed to your head. Yeah, if your brain is expanding, but your bone doesn't go anywhere, what happens? It gets squashed. So how do we fix the problem inside your head? Take the bone off, craniectomy, and close the skin up, but leave the bone off. Make it not a fixed space anymore. Or the other one is drill a hole and stick a EVD in there. Yeah, this is the stuff we've seen. Decrease the pressure by decreasing the volume. Now, in the sense of a baby growing in there, your volume is increasing with the baby. So yes, your kidneys and all do get squashed. One of the reasons why they don't advise people further on in pregnancy to sleep on their back. Yeah. Because what are you going to squash? Your kidneys, your vena cava, your aorta. And then if you squash your vena cava, what happens to blood flow through the veins? Less. And if there's less flow through, if there's less flow through the veins, there's back pressure into your legs. And will that blood move very quickly? And then what does blood do when it doesn't move quickly? Coagulates, DVTs, all those kind of words. Yeah? Does that make sense? The baby doesn't have to breathe. Again, the placenta gets blood from gets a kind of gas exchanges with the uterus wall. Yeah? So if you don't have enough pressure to your uterus, yeah, again, mean arterial pressure, uterine pressure, all those kind of things. Now, do you just massively vasodilate through all of that to get more blood to the baby? Yeah, you do. And what happens to your own blood volume? Well, people get very full of fluid. Yeah, they do all sorts of physiological things to account for that. Yeah. Now, is there a very fine line between good and bad? Yeah, and that's imagine stillbirth. The supply to the baby versus the demands from the baby are inadequate, and it just doesn't proceed to whatever. So again, one of the risks in theory of falling asleep on your back is stillbirth and all that kind of stuff. Very, very low probabilities, and for the most part, people move, but...
Can you feel it before it happens, though? Like, for example, the exercising on their back. Like, can they feel uncomfortable and move before that stuff happens? And it usually like
yeah.
Like, I have a few PT clients, and like, I always do the back side. Like, I don't think you should. But then she's like, well, I'll feel it before.
It's only for a short period of time. Like if you're asleep, you still move around a bit. Yeah. The problem is if you're like proper unconscious for, let's just say, other reasons, and you pass out on your back and don't move for 4 hours, then you're squashing things. Yeah. So it's not that it's on or off. It's like it's squashed a bit for a long period of time could be problematic. Squashed completely for a few minutes could be problematic, but you're not squashing it completely because it's all squishy. It all moves around. So it's a low-grade decrease in movement of blood across 4 to 6 hours, then that could be problematic. Yeah, but again, if they're exercising, is their heart rate higher? Is their cardiac output higher? Is their blood pressure higher? And the arteries push back. Your arteries are very high pressure. Yeah, they push back pretty well. But when you're asleep, is your heart rate higher or lower? And your blood pressure is lower. Yeah, does that make the difference? Yeah. So in exercise, your body copes with a whole bunch of stuff. Don't do that weird shit on the Swiss ball like one of those. What was that show about the fat people? Yeah, that one of the women from there was doing some really bizarre stuff. No, she was doing some bizarre stuff on a Swiss ball that was definitely not recommended. Do not listen to TV anythings about health. Exactly. So intra whatever pressure, you want to have an a perfusion pressure of more than 50. Yeah. Now your mean arterial pressure is about 90 if you have regular blood pressure. We can do the math, but this is all the math in here. Yeah, in millimeters of mercury. Now you got to push blood uphill. So is there more pressure or less pressure at the level of your brain than the level of your heart? Less. And is there more pressure or less pressure as you go downhill? More pressure. Think swimming pool. Go to the bottom of the swimming pool. Your head feels squashed by pressure because of the water above you. And as you come up from there, less pressure. Yeah. So if you have 90 here, you're going to have about 70 here. Yeah. And what is a normal range for intracranial pressure? 5 to 15. So let's just pick an average number of 10. So 90, 70 map minus 10 is 60. And then your vena cava jugular venous pressure is about 1. Yeah, 59, give or take. It's above 50. Your brain will be well perfused above 50. Less than 50, the perfusion is less. Yeah, so 0 is 0. Avoid that. Have no heart, you'll have 0 or cardiac arrest. But at 45, are you going to feel like you're getting adequate oxygen to your brain? And how will you feel? Dizzy. And what will you do? Lie down or faint. Because if you don't make yourself lie down, does your brain just say, I want more blood? And if you lie down, do you have to push blood uphill anymore? And therefore, the pressure here becomes the pressure here. And you don't have that loss of 20 millimeters of mercury, which is for pushing water uphill. That's 30 centimeters, give or take. Yeah, like that distance there is 30 centimeters. 30 centimeters is water pressure is 20 millimeters of mercury, because you've got to equate it. That make sense? So yeah, that's why you lie down. If they've just got postural hypotension and they're not bleeding, where's the blood gone? To their feet. So how do I get the blood back into central circulation? Lift your legs up. Yeah. Do we do that all the time? Yeah. Does it work? Somewhat. And then tell the nurse, and then run like hell. So your heart rate times stroke volume is your cardiac output, and make sure you document that you told the nurse before, anything else. And or the team. Yeah? We've all done that every day. Somebody drops their blood pressure in cardiothoracics or ICU because it's ICU. So why do they drop their blood pressure? Postural changes. Why else do they drop their blood pressure? Well, they've had heart surgery. So is the muscle going to be happy, or is the muscle going to have DOMS? DOMS. So you just trained legs, and now I'm asking you to go downstairs the next day. Are you going to go downstairs sensibly or unsensibly? Yeah, heart DOMS. And what are we trying to do when we move somebody's position? Make them go downstairs. And sometimes they cope, and sometimes they don't. Yeah. Preload is about blood volume. So if you are dehydrated, what happens to your blood volume? Decreases. And if your blood volume decreases, the volume in your ventricle decreases. And if there's less volume in, can I give you as much volume out? No. And that's it. Now, again, think about length-tension relationship. If there's less volume in your muscle, is your muscle in a shortened position? Can it generate much force in a shortened position? No, it wants to be in that nice middle position to generate maximal force. Does that make sense? And because your heart doesn't have connective tissue like that, it's not actually strong in a fully stretched position either. There is such a thing as too much preload, congestive cardiac failure. Yeah, you've all seen the x-rays. The people look like they have enormous hearts. So that is a ventricle that's too big. And the interconnection of the actin and myosin is a lot less than if it's there. Yeah? Really strong, barely holding on, too short. Make sense? I don't know. It's a cartoon I see in my head. Afterload is just diameter. So think vasodilation and vasoconstriction. Yeah? And if you vasodilate, what happens to your resistance? Less resistance. And if there's less resistance, what happens to your blood pressure? Lower. And that's that equation at the bottom there. Yeah? For the same cardiac output, if you have less resistance, you have less mean arterial pressure. So if you are vasodilated because you have sepsis, yeah, is that going to drop your blood pressure? Do you want to have a low blood pressure? So will you try and increase your heart rate? And will that fix the problem? Not fully. So you'll be tachycardic with a low systolic. Yeah, your heart rate will be higher than your systolic. Is that conducive to standing up or lying down? Lying down, yeah? As opposed to you and I, where your systolic is 100 and something, and your heart rate is 60 something. Systolic, higher than heart rate, good. If your systolic is 90 and your heart rate is 120, that's the wrong direction, yeah? So if your systolic is less than your heart rate, sad face. Just back to normal. In exercise, your heart rate goes from 80 up to 130, yeah? And your systolic goes from 110 up to 150, 160. What? Nothing. You stay lying down, all bad things happen. Well, if I stood you up with a systolic of 90, would you faint? I mean, you probably live there, but... Yeah? If you stand up too quickly, how do you feel? Yeah. The catch-up time. Yeah, but if you're already at 120, how much further do you have to go? As a 20-something-year-old, plenty. But as an 80-something-year-old, yeah? If they're 80, what's their heart rate max? 140. And if they're already at 120, how much heart rate reserve do they have? Not much. So they don't have far to go, and they're already hypotensive. Yeah, none of these things are a problem in you. You don't end up in ICU with these things. But if you're 70 or 80, you do. Yeah? Yeah? That's it. You're not having cardiac surgery unless you had a congenital valve abnormality or a septal defect. But the people we do see are 70 or 80. Yeah? So that heart rate reserve thing comes into it. Yeah, heart rate max equation. The distance that you can then travel. So, again, the equations, you don't need to know. Like, they show up on the screen when you're looking at an arterial blood. Yeah? And if you're doing the old school one, don't worry about it. Just use systolic. Like, that way you don't even need the stethoscope. Like, if you have the stethoscope and whatever, systolic and diastolic, but if you don't have that, and you just feel somebody's pulse and then pump up the blood pressure cuff, at a certain point, their pulse will disappear. Keep that number in your head. Open the thing up. At a certain point, their pulse will reappear. They'll be about the same number. That is their systolic. That is when blood is just squeaking past the pressure of the cuff. Yeah? And since most of the time, all we care about is a change in systolic for postural hypotension and so on, use that one. It's so fast to work out. Ah, there it is. We'll play with that, but does that make sense? For our purposes, the systolic is the most user-friendly number in a hurry. And then for medication and dobutamine and NORAD and all that kind of stuff, having the full map and everything else is important. But if they have those things, we already know they're in trouble. Yeah. If you're on inotropes, are you cardiovascularly unstable? Yeah. Are we very careful before moving people? Yeah. Do we still move them, but with the same amount of care? Yeah. Does that make sense? So don't worry about the equations. Just think about what is going on. If there's less volume, there's less preload, less volume. If the muscle is weak, less strength, less force generation, less flow. And if the arteries are dilated, that's a pressure problem. And if the arteries are constricted, what happens to pressure? Increases. And in the long term, can that be bad for you? What is the problem of being chronically hypertensive? What happens to your vessels? The surface gets very unhappy, and then you get scarring, which is atherosclerosis. Yeah? And then what happens to the ventricle itself? Does it get sad over time? Yeah, congestive cardiac failure further down the track. Yeah? Right or left, yeah? Depending on which side the problem is. So if it's peripheral hypertension, you're going to get left failure. If it's pulmonary hypertension because your lungs are bad, you'll get right heart failure. And can you have both? Yeah, smoking will pretty much give you both. You're going to have lung problems and peripheral circulation problems. Again, talk about pathology tomorrow. So during exercise, what do your mitochondria have to do? Make more? And what do they need to make more ATP? And oxygen and water. Because thinking about what is going on, it's a fire. Yeah. And if you have a fire, you need to move heat away. And if you don't move heat away, what happens locally? Burns. And what temperature do you start to denature protein? 42. Yeah. Answer to life, the universe, and everything. 42. Above 42 C, you start cooking like an egg. Yeah. At a pH of less than 6.7, you start to denature protein in a way that will be bad. Yeah. So in your heart itself, that will cause a ventricular fibrillation. If you go into ventricular fibrillation for having a blood pH of less than 6.7, what's going to happen to blood flow to your brain? Yeah, go to 0. What's going to happen to blood flow to your kidneys? Yeah, so that's why we need to start doing some of them very quickly. And then if you are fibrillating, we need to get you defibrillated. That's it. So in your mitochondria, you need to add oxygen and glucose, and you need to carry away heat and CO2. So if you carry away the things you need to carry away, then that's good. So if you are doing more work, we're going to get to this bit here. If you're doing more work, do you generate more CO2? Do you want that CO2 to stay local, or do you want it to move away? How do I get more blood flow somewhere? Vasodilation. And is vasodilation going to bring more blood to the area? Yeah, that's the pump. When you're feeling the pump and you're at the gym, you're vasodilating in your muscles. So if you vasodilate, do you bring in more blood? Yeah, and will that deliver more oxygen to compensate for the amount of CO2 you're generating? You'll bring in more oxygen automatically. And if you have adequate red cells coming in, you have adequate blood coming in. Does the blood have glucose in it? So should you get adequate glucose going to your cells? Yeah, that's all. So the CO2 vasodilates where it's needed. But if you vasodilate in a lot of muscles, what's going to happen to your blood pressure? Now, do you want to have a low blood pressure? So what does your heart rate do? Increase. Now, do you wait for your blood pressure to drop, or does your brain preempt? It preempts the heart rate and it preempts the respiratory rate. Yeah, we've all experienced this, just going upstairs and think, why do I feel puffed? You're not. Your brain's just going, oh, I'm about to exercise. And then you stop doing exercise. That's all. So cellular respiration is basically more oxygen comes in, more CO2 comes out, and that's it. Just more stuff going on because more stuff is going on. More fire. Yeah. So your heart rate goes up to increase your cardiac output. And if your cardiac output goes up, should your blood pressure also go up? Yeah, in normal circumstances. And in pathology, not so much. In your lungs, do you want to get more CO2 out? So where do you respond to CO2? What part of your body says, yes, there's too much CO2 in me? That's where the CO2 is. Where are the receptors, and what are they called? Not marrow, but chemoreceptors. And where are they? Yeah, in the carotid aorta and in your brain, in your pons. Yeah? Now, if you give somebody too many opioids, it stops your pons reacting to the CO2. So do you breathe more or breathe less? Yeah. Now, that's, again, the pathology type stuff. But in normal circumstances, the chemoreceptors say, I have too much CO2, breathe more. Yeah? If you have too much CO2, what happens to your pH? Drops. And do you want it to die? Is that going to make you breathe more? Yeah. Now, if you aren't getting enough oxygen, do you make CO2 or some other thing? Lactic acid. What does that do to your pH? Decreases. So does your brain want to have a low pH, or does it tell you to breathe more? Breathe more. Now, if for some reason you have a low sodium or too much chloride in your blood, does that also feel like a acidosis? Yeah, because chloride is hydrochloric acid in water. And will your brain say breathe more? Yeah. So that back to the why do you vomit? Well, you're just getting rid of chloride from your body to increase the gap between sodium and chloride, make you slightly more alkaline. Yeah, you'll hear of people taking bicarb before like sprint events and something like that. Yeah, what is bicarb? Sodium bicarbonate, alkali. And if you add alkali to acid, you get salt plus water, And because it's bicarbonate, there is a CO3 in there. Does that just turn into CO2? And then you burp the CO2 out. Yeah, just drink some bicarb. Now, what else do we use that reaction between bicarb and acid to make? Baking powder, which does what? Bubbles of CO2. And then you apply heat to the bubbles, and what do? Expand. Now, CO2 is bubbles. Do you want to have bubbles in your blood? So, are you dead right now? So your body copes with the CO2 by attaching it to the red cell. Yeah? And then all the extra stuff dissolves in water as HCO3, H2CO3, which is carbonic acid, which dissociates into the hydrogen ion and the HCO3. Yeah? And so that's a chemical reaction. Does it sound like a fast or a slow reaction? Slow. It's a slow reaction, carbonic acid. Now, what do you need? So what in chemistry, what do you need to speed up the rate of chemical reactions? And your temperature is the same, so you're not changing your heat? No? Or maybe, but not in this case. What are they called that speed up reactions other than heat? Starts with a C. Catalysts. And what is the, I guess, biology version of a catalyst? Enzyme. Now, enzymes are made of protein. Hemoglobin. Heme is iron, and oglobin is? So does the oglobin sound like a protein that might catalyze reactions? Does it sound like the kind of reaction where you would want to be turning CO2 into something that's not a gas? And that's where the speed up of the reaction to turn CO2 into carbonic acid increases in the red cells. And if you have more CO2 locally, do you have vasodilation locally? And does that bring more blood to the area and more red cells? See how you're not dead? And all those things they tell you to worry about are just normal physiology. Now, if you don't breathe, do you get the CO2 out of your mouth? So what's going to happen to the CO2 in your blood? Increase. Now, it doesn't increase indefinitely, because if you don't breathe, do you get oxygen in? And if you don't get oxygen in, are you having aerobic or anaerobic metabolism? Anaerobic. So are you making CO2 or some other thing? Lactate. So what's going to happen to your CO2? It'll peak and not go any higher because you're not making any more CO2. But what will your lactate do? So a respiratory acidosis becomes a metabolic acidosis just by going from breathing less to breathing zero. They're not separate things. Yeah? The solution is always panic, which is increase your respiratory rate and increase your cardiac output. That's how you know they're not separate things. There's the same solution to both of them. Make sense? People use those things. I want you to separate that and call it a ventilation issue, gas movement, or an electrolyte issue. Because if you think about it as electrolytes, does carbon dioxide dissolve in water? Yeah, carbonic acid. Does lactic acid dissolve in water? Yeah. Does sodium and chloride dissolve in water? Mess with your sodium and chloride and you will have an acidosis or an alkalosis. Yeah. Now, the simple way to understand that is, in a normal person, do they have more sodium or more chloride? More sodium. What is the pH of water at standard temperature and pressure? 7. What is your pH? 7.4. You have more sodium and you live the alkali side of neutral water. That's buffering and all those other things. Why? You literally just have more alkali because you have more sodium. Despite the fact that almost every process in your body is acid forming, yeah, except for one. The one not acid forming, I'm going to say, and my chemistry is sketchy, but ammonia. Yeah, ammonia is an alkali-ish kind of thing. Yeah. So where you have a lot of acidy kind of things, like in your kidneys, yeah, there's a lot of electrolytes that need to be balanced. You'll use ammonia there to just offset that pH. In your liver, again, you're breaking down amino acids to make glucose, gluconeogenesis. The remnant is the amine amino acid, ammonia. Yeah. So all those things, crazy chemistry, but just remember, most of your chemistry is acid forming, and that's why you need to breathe. To get acid out your mouth fast, to get oxygen in to make less acid, and to balance other things. And then the failure of that is using other systems. So vomiting is another system that's very quick. And then the slow systems is balancing your electrolytes using your kidneys. Can you do that in 4 minutes or 4 hours? 4 hours or 24 hours, whatever. Yeah, make sense? That's it. Failure of any of those things, it'll hurt. And then you may or may not die depending on how quickly they can fix the problem.